You know that moment when a newborn takes their very first breath? It's something we often just take for granted.
Absolutely.
But imagine if that breath was a real struggle, a real effort. Sometimes this difficulty can stem from a condition called congenital diaphragmatic hernia, or CDH.
Right.
It may
CDH.
not be something you hear about every day, but it affects around, what, 1 in every 2,000 babies?
That's about right. Yeah. And in this deep dive, we're going to unpack CDH using some pretty detailed revision notes.
Okay,
Our goal really is to give you the key information, the sort of core nuggets you need to understand this condition thoroughly and, efficiently.
great. Okay, so congenital diaphragmatic hernia, CDH. Let's start right there. What exactly is it?
Well, simply put, CDH is a birth defect where there's a hole, an opening in the diaphragm.
Okay, the diaphragm, that muscle separating the chest and the abdomen.
Exactly. And this hole lets organs that should be down in the belly, think intestines, maybe the stomach to move or herniate up into the chest cavity.
And that's got to cause problems with breathing, I imagine.
Huge problems, yeah. The main issues we see are pulmonary hypertension, that's high blood pressure specifically in the baby's lungs,
Right.
lung hypoplasia, which just means the lungs haven't developed full,
Developed, okay.
exactly, underdeveloped, and also something called surfactant dysfunction. Your lungs have these tiny air sacs, right? And they need this sort of soapy substance, surfactant, to keep them open.
Makes breathing easier.
Precisely. And in CDH, that surfactant might not be working correctly. The underlying reason for all this, basically the diaphragm doesn't completely fuse, doesn't close up properly while the baby's developing in the womb.
So it's a structural issue right from the get-go. Now, the notes mention three main types of this hernia. Let's start with the most common one, Bochdalek's hernia.
Bochdalek, yep, that's the most frequent by far. Makes up about 85% of CDH cases. It's typically on the left side.
Left side, okay.
And because it often involves a sort of bigger gap in the diaphragm, it can lead to pretty significant challenges with both lung and heart development. A helpful way I sometimes think of it is Bochdalek's is back, and usually on the left, because it's typically a posterolateral defect in the back and to the side.
Bochdalek's is back and usually on the left. I like that.
Yeah.
Got it. What's next?
Okay, the next type is Morgani's hernia. This one's much rarer.
Yeah.
It happens more towards the front of the diaphragm through an opening called the foramen of Morgani. I guess the slightly better news with Morgani's is that they're often repairable using laparoscopy, minimally invasive surgery.
Ah, okay.
So you could think Morgani's is more forward.
Morgani's is more forward.
Right.
And the third type,
That's the hiatus hernia. Now, you might have heard of this in adults, often linked to reflux.
heartburn and things.
Exactly. And in the context of CDH, it's also associated with reflux disease in infants. Usually, surgery is only really considered if the reflux is severe and isn't getting better with other treatments.
Okay. So we know what CDH is, the different types. But what actually causes it? Why does this happen?
Yeah, that's a really key question. And the honest answer is the exact cause of most CDH is currently unknown. We call that idiopathic.
Right, idiopathic, no single trigger identified.
Exactly. But the current thinking is that it's likely multifactorial. So a combination of things, genetic factors, and maybe environmental influences interacting during pregnancy.
So it's complex, not just one thing. But the notes do mention some potential contributors, right?
They do. We're looking at possibilities like specific genetic mutations, changes in the genes,
Okay.
chromosomal abnormalities, so bigger changes in the genetic material, and potentially exposure to what we call teratogenic substances.
Agents that can cause birth defects.
Precisely. Things that interfere with normal development in the womb.
Okay. So moving on to risk factors then, it sounds like if the cause is mostly unknown, predicting risk is hard.
That's true. For the majority of cases, we really can't pinpoint a clear, specific risk factor. But the revision notes do highlight some associations that are worth knowing about.
Like familial clusters and chromosomal issues. Tell me about those.
Right. So familial clusters, where you see it run in a family, it's actually pretty rare, less than 2% of cases.
Okay.
But on the other hand, around 30% of CDH cases are linked to some kind of chromosomal abnormality.
30%, that's quite significant.
It is. And the fact we sometimes see these rare family clusters suggests that in those specific instances, it might be down to multiple genetic factors working together, what we call multifactorial inheritance.
Right.
There's even a specific spot on chromosome 15q24, q26 that seems to be associated with CDH sometimes.
So if a family has had one child with CDH, what's the risk for another pregnancy?
The estimated recurrence risk is about 2%. Not huge, but definitely something families need to be aware of for counseling and planning.
Makes sense. And the notes also mention some maternal factors.
Yes, things related to the mother's health or exposures during pregnancy. These include maternal smoking,
Okay.
maternal diabetes, the use of certain medications, SSRIs, the antidepressants are specifically mentioned.
Right, selective serotonin reuptake inhibitors.
Exactly. And also advanced maternal age. These have all been linked to a slightly increased risk. And finally, it's worth remembering that some specific genetic syndromes can also carry an increased risk of CDH.
It really paints a picture of, well, complexity. Genetic predisposition, maybe environmental triggers. So let's dig into what's actually going wrong physically, the pathophysiology.
Okay, so the absolute core issue is that the diaphragm fails to close completely during fetal development. Simple as that, fundamentally.
Leaving that hole.
Leaving that hole, the hernia.
Mhm.
And through that hole, abdominal organs, intestines, stomach, sometimes liver or spleen, can move up into the chest cavity.
And that upward movement must really impact things.
Oh, definitely. It has a huge impact. Those organs in the chest take up space, vital space that the developing lungs need to grow.
Right.
So this physical compression leads to that pulmonary hypoplasia we talked about, the underdeveloped lungs, which means the respiratory system isn't ready to work properly after birth. And it doesn't just affect the lungs. The heart can also be squashed or pushed out of place.
So cardiovascular issues too.
Yes, absolutely.
Yeah.
Both systems are compromised.
The notes mention something about the pleuroperitoneal canal not closing. What's that?
Ah, yes. So during development, there are these temporary openings called the pleuroperitoneal canals. They're supposed to close up completely as the diaphragm forms.
But sometimes they don't.
Exactly. If they fail to close properly, it creates a direct pathway for those abdominal organs to herniate into the chest. And just to link back, that left-sided posterolateral Bochdalek hernia, the back and usually on the left one,
Yeah.
that's the most common type, often because it results from this specific failure of the pleuroperitoneal canal to close.
Okay, that makes sense. So if a newborn is really struggling to breathe, CDH is on the list, but what else are doctors thinking about? The differential diagnosis.
Good question. You always need to consider other possibilities that could cause similar symptoms. So in a newborn with respiratory distress, doctors would definitely think about a pneumothorax, a collapsed lung,
Right.
or maybe a pleural effusion, which is fluid buildup around the lung.
What if the baby inhaled something like meconium?
Yes, aspiration syndromes are definitely on the list. And critically, persistent newborn pulmonary hypertension, or PPHN. That's where the high blood pressure in the lungs doesn't drop like it normally should after birth. That can look very similar initially.
Okay.
And of course, any other general cause of breathing problems in a brand new baby needs to be considered too.
Now, the notes also talk about associated diseases. It sounds like CDH isn't always an isolated problem.
That's a really key point. It often isn't isolated. Posterolateral hernias, the common Bochdalek type, are frequently seen alongside other congenital anomalies, other birth defects, up to 40% of cases.
40%? Wow. Like what kind of defects?
They can affect various systems: cardiovascular, so heart and blood vessel problems, genitourinary, like kidney or bladder issues, and gastrointestinal problems beyond the hernia itself. Interestingly, the rarer retrosternal hernias behind the breastbone also have this higher association with other malformations.
And unfortunately, sometimes these associated conditions are very serious.
Yes, sadly. Lethal anomalies, meaning conditions incompatible with life, are present in up to 16% of infants born with CDH.
16%.
And we also see those chromosomal abnormalities we touched on earlier in about 4% of infants with CDH. The notes list specific ones like Trisomies 13, 18, and 21 Pataus, Edwards and Down syndromes, plus Turner syndrome and Pallister-Killian syndrome.
Okay.
And there's also a known link with a non-chromosomal disorder called Cornelia-de Lange's syndrome.
It really emphasizes the need to look at the whole baby, not just the diaphragm defect. So how common is CDH overall? What's the epidemiology look like?
Well, the incidence is estimated somewhere between 1 in 2,500 and 1 in 3,000 live births,
Okay.
which might sound rare, but it actually accounts for about 8% of all major congenital defects. So it's significant in that context.
Right. Are there any patterns? Like, does it affect boys or girls more?
There's a slight tendency for it to be more common in males. The ratio is roughly 3 males to every 2 females.
Yep.
And as we've said, the left side is much more common. About 85% of cases are left-sided. Right-sided CDH only happens in about 10–15% of cases.
And why is right-sided Rarer.
It's thought that the liver, being large and on the right side, might physically block or obstruct the organs from herniating up as easily on that side.
Makes sense. And I think I read somewhere that right-sided CDH can sometimes be, well, more challenging.
That's generally true, yes.
Yeah.
Right-sided CDH does tend to be associated with higher rates of mortality and morbidity, meaning a greater risk of death and complications, unfortunately.
Okay. So let's picture a newborn baby. What are the typical signs, the clinical features that would make a doctor suspect CDH?
Often the presentation is quite dramatic right after birth. You'll usually see severe respiratory distress. The baby's working incredibly hard to breathe.
Okay.
Cyanosis is common, that bluish tinge to the skin, lips, or nail beds, showing lack of oxygen. They might be breathing very rapidly, tachypnea. And when a doctor listens to the chest, the lung sounds might be abnormal or absent on the affected side, and sometimes you might even hear bowel sounds in the chest.
Bowel sounds in the chest. That's a big clue.
It's a very telling sign, yes. And another key physical finding can be what's called a scaphoid abdomen. The belly looks sunken or concave because the organs that should be filling it out are up in the chest.
Right, leaving the abdomen looking empty.
Exactly. And as we mentioned, some babies might also have other obvious physical anomalies pointing towards a specific genetic syndrome. Now, sometimes the diagnosis is made before birth
On ultrasound.
on a routine ultrasound, exactly, which is great because it allows the medical team to prepare. But in other cases, it's only suspected or confirmed after the baby is born and showing these symptoms.
Okay.
And just as a side note, very occasionally, CDH can present much later childhood or even adulthood. These late presentations are usually less severe and have a better prognosis.
Interesting. So if CDH is suspected, either prenatally or after birth, what investigations are done to confirm it and assess the baby?
Well, if it wasn't picked up before birth, the first step is usually a chest x-ray right after birth. That often gives a very clear picture, showing loops of bowel or other organs up in the chest cavity.
Okay, x-ray first.
An ultrasound scan of the chest can also be helpful. And it's important to specifically look for a pneumothorax, that collapsed lung, because that can sometimes occur as a complication.
And checking oxygen levels must be critical.
Absolutely. Blood gas analysis is essential. This measures oxygen, carbon dioxide, and pH levels in the blood. It helps assess for that persistent pulmonary hypertension and also for something called right-to-left ductal shunting, where blood bypasses the lungs, both common issues in CDH.
Right.
An interesting point is that the PaO2, the oxygen level, might look artificially higher if the sample's taken preductally, say from the right arm, compared to a postductal sample from a leg.
Ah, okay. Good to know. What else?
Routine blood tests are done too, checking electrolytes, calcium, glucose, standard newborn checks, but especially important here.
And what about checking for those other associated problems we talked about earlier?
Exactly. A cardiac ultrasound, an echocardiogram, is standard to check the heart structure and function. And an ultrasound of the urinary system, the kidneys and bladder, is also usually done.
Makes sense.
And given the potential link with neural issues, a cranial ultrasound to look at the brain might be performed, checking for things like hydrocephalus or neural tube defects. And finally, in some cases, chromosomal analysis, checking the baby's chromosomes, might be considered.
Okay, comprehensive workup. So a baby's diagnosed with CDH. What's the immediate management strategy?
Immediate care is absolutely vital, especially if it wasn't diagnosed prenatally and the baby arrives in distress. The first priorities are to reduce the pressure in the chest from those herniated organs and get oxygen levels up. Well, if bowel sounds are heard in the chest, resuscitation might be done with the baby slightly head up. For severe cases presenting early, endotracheal intubation, placing a breathing tube, and mechanical ventilation are usually needed very quickly.
And I remember reading something specific about not using bag and mask.
That's a crucial point, yes. Avoid bag and mask ventilation in the delivery room if you suspect CDH. Why? Because it can pump air into the stomach and intestines that are up in the chest.
Making the compression worse.
Exactly. Makes the breathing problem even worse. Instead, an orgastric tube, a tube through the mouth into the stomach, should be placed immediately to decompress the stomach and bowel. An X-ray then confirms its position.
Okay.
Early use of surfactant, that lung-opening substance, might also be beneficial. And throughout all this, you need continuous monitoring of blood gases and usually arterial and venous lines for giving fluids and medications safely.
Right. Once the baby is stabilized a bit, what's the non-surgical plan?
The focus then shifts to optimizing oxygenation, while trying very hard to protect the fragile lungs from ventilator-induced injury, what we call barotrauma.
Gentle ventilation.
Gentle ventilation strategies, yes. It involves intensive care support, ongoing ventilation, careful blood pressure management, watching glucose and calcium levels closely. There's actually some ongoing debate about the precise target levels for oxygen and carbon dioxide in the blood for these babies.
Okay.
Sometimes a treatment called alkalinization, using sodium bicarbonate, might be tried for rapid pulmonary vasodilation, opening up those lung blood vessels to help with the hypertension. And the use of inhaled nitric oxide, another pulmonary vasodilator, is also a bit controversial and not universally standard.
So, supportive care, optimizing physiology, but ultimately surgery is needed to fix the hole, right?
Yes, surgical repair is the definitive treatment. The surgeon carefully moves the herniated organs back down to the abdomen where they belong, and then closes the defect in the diaphragm, sometimes using a patch if the hole is large.
And when does that happen? Immediately.
Actually, no. The preferred approach now is delayed surgical repair. Generally, they wait until the baby's pulmonary artery pressures have been stable for about 24 to 48 hours. Rushing to surgery too early can sometimes destabilize the baby.
Okay, stabilize first, then operate. What if the baby is really struggling to get enough oxygen even with the ventilator?
In those very severe cases, a treatment called ECMO, extracorporeal membrane oxygenation, might be used.
The heart-lung bypass machine.
Essentially, yes. It takes over the work of the heart and lungs, allowing the baby's own lungs to rest and hopefully recover a bit before attempting the surgical repair. It's a major intervention, usually reserved for the sickest babies.
Is the surgery itself risky?
Any major surgery on a newborn is risky, and there's definitely a risk of the baby's circulation and breathing becoming unstable after the repair. But surgical techniques have improved. Thoracoscopic repair using keyhole surgery is now considered safe and effective in many centers and may lead to quicker recovery for some.
Wow. Now, the notes also mentioned fetal surgery. That sounds incredible.
It is pretty amazing stuff. Though direct repair of the hernia in utero isn't currently feasible, what is being done in highly specialized centers is a procedure called fetal tracheal occlusion, or ATO.
Blocking the windpipe, how does that help?
It sounds counterintuitive, right?
Yeah.
But the idea is, by temporarily blocking the baby's trachea, the normal fluid produced by the lungs gets trapped. This buildup of fluid actually stretches the airways and seems to stimulate lung growth, potentially reversing some of that hypoplasia and improving the lung blood vessels.
That's fascinating. How is it done?
It can be done either via open surgery on the uterus, which is very invasive for the mother, or increasingly through photoscopy, using a small camera and instruments inserted into the womb.
Wow.
There are very specific criteria for selecting candidates based on things like how much lung tissue they seem to have on ultrasound and whether the liver is herniated into the chest. The optimal timing and how long to keep the trachea blocked are still being actively researched.
Incredible technology. So, putting it all together, what's the outlook? What's the prognosis for babies born with CDH?
It's really variable and depends heavily on several factors. The biggest one is the severity of the pulmonary hypoplasia, how underdeveloped the lungs are.
Makes sense.
Also, the presence of those associated anomalies we discussed. Having other major birth defects definitely impacts the prognosis. And crucially, access to specialized neonatal intensive care, including ECMO capability, makes a huge difference.
Right.
Little things can matter too, like continuously decompressing the bowel with that NG tube seems to improve outcomes. And as you'd expect, the more severe the pulmonary hypertension, the higher the mortality risk. Other factors like birth weight, gestational age, whether the baby was born at the specialist center versus transferred in, and needing ECMO, they all influence survival chances.
And does that fetal surgery actually improve the prognosis?
For carefully selected babies who undergo FETO, yes, the prognosis does seem to be improved. Part of that might be the intervention itself stimulating lung growth, but it's also because these are planned deliveries at expert centers with immediate optimized care ready to go.
So preparation is key.
Absolutely. Antenatal diagnosis is so valuable. With it, survival rates can reach up to 80% in optimal settings because everyone is prepared. The delivery is planned, resuscitation is immediate and expert, and ECMO is available if needed.
Are there specific signs during pregnancy that might suggest a poor outcome?
Yes, some prenatal findings are considered negative prognostic indicators. Seeing the fetal stomach way up in the chest on ultrasound is one. Maternal polyhydramnios, excess amniotic fluid can be another. The presence of associated major malformations, as we said. And sadly, bilateral hernias, holes on both sides, are typically fatal.
So what's the bottom line, the overall survival rate?
Overall, averaging everything out, the survival rate is often quoted around 50%. But I really have to stress that number varies hugely depending on the center, the severity of the individual case, and associated factors. It can be much higher in specialized units for isolated CDH diagnosed prenatally.
Okay. So for the babies who do survive, what are the potential long-term challenges?
Complications. Yes. Unfortunately, long-term complications are common for survivors. Respiratory issues are very frequent. Many develop chronic lung disease, sometimes with both obstructive and restrictive patterns.
So ongoing breathing problems.
Often, yes. They might need prolonged ventilator support or supplemental oxygen. Diuretics are sometimes used for fluid management, but have potential side effects like electrolyte imbalances. The long-term impact of using steroids, which are sometimes given to help the lungs, on both lung and brain development is still a bit debated. And some babies have persistent pulmonary vascular problems, leading to difficult-to-treat pulmonary hypertension later on.
What about other systems? The notes mention nervous system issues.
Yes, that's a significant concern. The potential for hypoxemia, lack of oxygen around birth and in the early days, can unfortunately lead to nervous system injury. CT scans might be used to assess for any brain injury.
Okay.
And there's a surprisingly high incidence of hearing loss in CDH survivors. So hearing checks are really essential before discharge and again at around 6 months.
Hearing loss. Okay.
And developmental follow-up is crucial. These kids need regular developmental assessments for at least the first 3 years, often longer, maybe with another check before starting school, to catch any delays early and provide support.
And finally, feeding problems seem common too.
Very common, yes. Significant gastroesophageal reflux, GERD, happens a lot, probably because the stomach and esophagus junction isn't in the normal position or under normal pressure.
Right.
Medical management with acid-reducing meds is the first step, but sometimes surgery, like a Nissen fundoplication, is needed to control severe reflux. All this can contribute to failure to thrive, poor weight gain, due to higher energy needs from breathing effort, feeding difficulties, and the reflux itself.
And does that reflux persist?
It can. Studies looking at adults who had CDH as infants show a higher rate of esophagitis, inflammation of the esophagus. And there's even a potential long-term risk, though small, of developing Barrett's esophagus, which is a precancerous condition.
Wow. It's really clear that CDH is a major condition needing lifelong awareness and often ongoing care.
It absolutely is. It requires a huge multidisciplinary team effort. But, the important takeaway is that thanks to advances in prenatal diagnosis, neonatal intensive care, surgical techniques, and ECMO, the outcomes are improving. We're seeing more babies survive and thrive.
That's definitely encouraging. It really highlights the value of early detection and getting these babies to specialized centers. For anyone listening who wants to dive deeper into this or other pediatric topics for revision, definitely check out PassThemSRA.com and FreeMSRA.com. Loads of great resources there.
Absolutely recommend them.
Okay, well, that brings us to the end of this deep dive on congenital diaphragmatic hernia. A complex topic, but hopefully that's provided a clear overview. Thanks for joining us.